So I believe my screen is visible now.
Yes, sir. It is visible and your slides are visible.
Yes. So the topic which I have chosen for this webinar or the lecture series is oncological emergencies. It's a very, very important topic, and I think all the pediatrician, the postgraduate student must be aware about identifying the oncological emergencies. So if we talk about childhood cancer, around 40,000 to 50,000 new cases of childhood cancer happen in India every year, which is a significant number. Till now, the majority of deaths were happening due to infections, but with advent of infection prevention control, good antibiotics, awareness, the deaths due to infections are declining. And now focus of everybody is shifting towards non-communicable diseases, and cancer is one of the leading causes of deaths among non-communicable diseases. If you talk about developed countries, around 80% of children with cancer would survive and only 20% would die. But this is in contrast to lower middle income countries like India, where around 80% of children with cancer would die and only 20% would survive. And the cause of death in these two regions is different. You know, in developed countries, while majority of cancer patients die because of relapse or refractory disease, but in lower middle income countries, it does happens even before the diagnosis of cancer. It happens because of various complications, various emergencies. So we need to identify these patients. Patients are dying even before reaching a cancer center, even before a diagnosis is made. So we have to prevent this by being aware of what presentations a cancer can have, what complications a cancer can happen in a child with cancer. So early recognition and timely treatment initiation are essential to improve survival. And this is also in sync with the WHO Global Childhood Cancer Initiative, which aims to improve the survival to at least 60% by 2030 all over the world. So WHO aims that by 2030, 60% children with cancer should survive, be it any developing country. So for India as well, this should hold true. So we have to take steps in that direction. And this cannot happen without a teamwork. So as I told you that many patients in India die even before they reach the cancer center. So we don't need pediatric oncologists to identify cancer. We need pediatricians. We need our students, our postgraduates to identify childhood cancer, identify the emergency, and make a proper initial treatment, initial workup, and then only refer a patient. We should not think कि diagnosis बन गई जल्दी से जल्द उसको भेज दिया जाए. We should have a proper workup, stabilize the patient, manage the emergency, and then send a patient with cancer. So the learning objectives for my today's talk would be to enumerate the common oncological emergencies in children, identify the risk factors associated with oncological emergencies, and the current evidence-based management of oncological emergencies. Oncological emergencies can be categorized into various groups. So I have used one such classification. So the most common emergency is infection. So infections also called as febrile neutropenia. So this febrile neutropenia can happen even before starting treatment, but most of the time it happens after the initiation of myelosuppressive chemotherapy. So febrile neutropenia is one of the leading causes of death in children with cancer. Then there can be metabolic complications like tumor lysis syndrome, syndrome of inappropriate ADH secretion, hypercalcemia, renal complications like obstructive uropathy by tumors which are compressing the renal excretory system, renal failure because of drugs, renal failure because of infection, renal failure because of say tumor lysis. So renal complications can also happen. Cardiopulmonary complications like pleural effusion, pericardial effusion, superior mediastinal syndrome, neurological complications like seizures, altered sensorium, cord compression, abdominal complications, the intestinal obstruction, especially seen in children with non-Hodgkin's lymphoma of the intestine, perforation, neutropenic colitis, pancreatitis, again commonly seen due to drugs like elasparaginase used for treatment of children with ALL, and hematological complications like hyperleukocytosis, severe anemia, and bleeding because of thrombocytopenia, bleeding because of coagulopathy. So you can see emergencies in children with cancer can be of various types. Now, all of you are versed with common management algorithms, for example, managing renal failure, managing seizures, So they are, as a child without cancer, they are almost similar. So we would be focusing on certain unique emergencies which you have to identify them, and management is a bit different from other pediatric emergencies. So we would be focusing on tumor lysis, superior mediastinal syndrome, febrile neutropenia, neoplastic cord compression, and hyperleukocytosis. So we will briefly, with a case-based approach, see how to identify and treat these complications. So we begin with our case. So we had a 12-year boy who was brought to the emergency room with complaints of cough, shortness of breath, and orthopnea for the last 15 days. When this child was examined in the ER, it was found that he was drowsy and confused. There was some facial swelling. The veins in the neck were dilated, and the child was having respiratory distress in the form of tachypnea and retractions. And the right cervical lymph node was palpable, around 4 into 5 centimeters. It was a firm, non-tender cervical lymph node. Now, this child fortunately had a chest X-ray as well as a CT scan with him when he came to our emergency. So I'll show you the images of his X-ray and the CT scan. Now, this was his chest X-ray PA view. Now you can appreciate that on the right side, the costophrenic and the cardiophrenic angles are obliterated, while you can appreciate these angles on the left side, which means there is some effusion and there is an opacity in the mediastinal region. In fact, the cardiac borders and that opacity, it's very difficult to differentiate. So most likely there is a mass in the mediastinum along with some pleural effusion. Even the CT, the same findings are confirmed. You can see this is the coronal and this is the sagittal sections. In the coronal section, you can see this is the pleural effusion on the right side. And this is a mediastinal mass, which is causing the shifting of heart and other mediastinal structures to the left side. So this is the heart which has been pushed towards the left side. And this is a solid mass in the mediastinum and with an associated significant pleural effusion. And you can also see that this mass is extending into the neck. And here you can appreciate a cervical lymph node which was palpable. Based on the clinical presentation and imaging, which of the following is the most likely diagnosis in this child? So these are the differential diagnoses which were kept by the resident physician who examined this child. We would start from bottoms up. So severe pneumonia with empyema thoracis was the first possibility which was kept. But this looks unlikely, especially in view of that cervical adenopathy, which is a firm, non-tender lymph node, and the X-ray showing a mass in the mediastinum. So severe pneumonia with empyema looks quite unlikely. Then among the neoplasm, the possibility which were considered were neuroblastoma, but neuroblastoma is primarily a malignancy of younger kids. He's a 12-year-old. There is no abdominal mass, so less likely to be neuroblastoma. Askins tumor it's a type of primitive neuroectodermal tumor of PNET. They typically arise from the chest wall. Now, in this child, there was no swelling over the chest. Even on the X-ray and the CT scan, the bones looked normal. So less likely to be an Ewing's sarcoma or the PNET. The next possibility was lymphoma. Now, lymphoma is of two types, Hodgkin's and non-Hodgkin's. Based on the history and physical examination, this looks more likely to be a non-Hodgkin's lymphoma, because Hodgkin's lymphoma is a slowly growing tumor. The children get time to adapt to the lymphadenopathy. So there is no such respiratory distress at presentation in this child. The history was short, and the child was showing features of respiratory distress because of the mass. So more likely to be a non-Hodgkin's lymphoma with superior mediastinal syndrome. So based on the clinical presentation, the most likely diagnosis which we considered was a non-Hodgkin's lymphoma with superior mediastinal syndrome. Now, what is a superior mediastinal syndrome? So whenever there is a mass in the mediastinum and it is growing too rapidly, it compresses the structures which pass through the mediastinal inlet. And these structures include the vessels like superior vena cava, the airway, the trachea, and even the esophagus. So the malignant mass can compress these structures, leading to various clinical presentations. So children are at greater risk of developing superior mediastinal syndrome because the pliable nature of the trachea, it's more amenable to compression, and also because the overall diameter of the thoracic inlet is less. Tumors which can present with superior mediastinal syndrome include non-Hodgkin's lymphoma, TALL, germ cell tumors, certain sarcomas like Ewing sarcoma and neuroblastoma. So these all tumors can present with SMS. The clinical features arise from the structures which are compressed, which would include a venular dilatation, edema of the neck and face. There can be increased intracranial pressure because the venous return from the brain is also hampered because of compression. There can be cough, respiratory distress, and dysphagia. There can be pleural and or pericardial effusion as well. So what are the points in favor of the second option, that is NHL with SMS? Because it was a rapidly growing tumor, associated cervical adenopathy pointing towards a lymphoma, mass arising in the anterior mediastinum, the neural origin masses like neuroblastomas, Ewing sarcoma predominantly arise from the posterior mediastinum, and signs and symptoms of superior mediastinal syndrome as well as superior vena cava obstruction were present in this child. So most likely he has NHL with SMS. On further investigating this child, his complete blood count was almost unremarkable. The total count, differential count, hemoglobin and platelet counts were normal. The LDH was quite high, a value of 4,000, which just indicates that the tumor burden is quite large. His serum electrolytes, urea, creatinine, and uric acid at baseline were normal. So which of the following represents the most appropriate method to confirm the diagnosis? So we are suspecting that this child is suffering from NHL with SMS, but this information is not sufficient to initiate treatment. We need to get a confirmatory diagnosis. So among these following 5 choices, which would be the most appropriate method? Whether a PET-CT, a bone marrow aspiration or biopsy, biopsy from the mediastinal mass under general anesthesia, biopsy from the enlarged cervical lymph node under general anesthesia, or biopsy from the cervical node under local anesthesia. In the next slides, we would try to reach to the final answer for this question. So for superior mediastinal syndrome, the first step in diagnosis is doing an imaging. So when we are suspecting a child has SMS on clinical grounds, we do an imaging to localize the mass, and imaging we should prefer to do at least a CT. So X-ray and a CT scan should be done. After obtaining the imaging, once the imaging confirms that the child has neoplastic swelling or neoplastic mass in the mediastinum, we need to obtain tissue. So least invasive method for tissue diagnosis should be chosen because we have to avoid sedation. The child's airway is already compromised. If we sedate such a child, his airway may collapse. The child may develop cardiorespiratory arrest. So we have to, by all means, we have to avoid sedating such a child. The management would be supportive in the form of oxygen inhalation, keeping the head end a bit elevated, maintaining calm in that child. And IV line should be secured in the lower extremities, because if we put IV access in the upper extremity, that would be drained to the superior vena cava, which is anyway compromised. So avoid securing an access in the upper extremities, choose the lower extremities. This is the algorithm for any child with suspected superior mediastinal syndrome. First step is imaging to confirm the diagnosis. Then we do other ancillary studies like a complete blood count, other studies based on your suspicion, maybe a bone marrow. And if the other studies are diagnostic, we treat such a child. But if we are unable to obtain diagnosis from other studies like bone marrow, from the lymph node studies, if we are unable to obtain a diagnosis, then we should first generate the differential diagnosis and assess the child's risk to tolerate anesthesia. If we feel that the risk of anesthesia is low, that means the child is comfortable, he's maintaining his saturations on room air, he's not having a lot of distress, then we can consider doing an image-guided biopsy, and based on the biopsy reports, we will treat such a child. But if the child has already features of airway obstruction, he is at high risk of anesthesia, then we may have to treat him empirically. And after this empirical treatment, we would reassess. Once the child is showing some response, we would again assess his anesthesia risk and do a biopsy, because empirical treatment can be given for the initial few days only. We cannot decide the entire treatment empirically. We need to have a final diagnosis from the biopsy. So a biopsy is must. If child is fit, upfront biopsy. If unfit, give some treatment and do biopsy later on. So what empirical treatment can be considered? If we are suspecting lymphoid malignancies like NHL in this child, empirical steroids may be considered if the child is developing features of respiratory failure. Empirical radiotherapy can be considered for radiosensitive tumors. And in certain scenarios, even chemotherapy with broad spectrum drugs like cyclophosphamide or doxorubicin may have to be given in patients who are not responding to your steroids or where you are suspecting sarcomas and child is unfit for a biopsy. So after going through all of this, we know now that the answer for that question should be biopsy from the enlarged cervical lymph node under local anesthesia. We should avoid touching the mediastinal mass because we would need sedation, and that would make the child at risk for airway compromise. Biopsy under GA again from the cervical lymph node would be risky. So local anesthesia and biopsy of the cervical lymph node should be done. A PET-CT would just tell you the stage of disease. It is not going to give you the confirmed diagnosis. Bone marrow aspiration biopsy you're going to do, but because the child did not have any cytopenia, so the chances that bone marrow will give you a diagnosis are quite low. But anyway, you would always do a bone marrow in a child where you're suspecting NHL. It may be suggestive, it may be involved, but in this child, looking at the CBC, absence of hepatosplenomegaly, chances of marrow involvement are quite less. So we would go for biopsy from the cervical lymph node under local anesthesia. One more investigative modality which could have been done in this child was cytology of the pleural fluid. Because this child has pleural effusion, we can tap that fluid and subject that fluid to flow cytometry. Because nowadays, flow cytometry can accept samples not only of blood, but also from tissue fluid. So the pleural fluid can be subjected to flow cytometry and you can get a diagnosis from a non-invasive method even with that method. So confirmation of diagnosis, there is a risk of sedation and anesthesia. So we will choose the least invasive method, that is local anesthesia and cervical lymph node biopsy, or a pleural fluid aspiration and flow cytometry from that fluid. PET-CT would just help in staging, it will not confirm your diagnosis. Now coming to the further course of this child, he was started on oxygen inhalation, propped up position. He was started on IV hydration. A biopsy from the cervical lymph node was performed under local anesthesia. But the biopsy reports usually take at least 3 to 5 days to return. So meanwhile, the child's respiratory distress continued to progress. Because we were suspecting a non-Hodgkin's lymphoma, we started this child on prednisolone at 60 mg per meter square per day. So after 1 day of starting prednisolone, once we repeated his lab values, the values came back as his potassium had elevated to 6.2, his calcium had dipped to 0.7, his phosphate values were high at 8.5, and his uric acid values, which were initially normal, have now jumped to a value of 18.2 milligram per DL, and his creatinine, which was initially normal, has increased to 2 milligram per DL. So these abnormal biochemical values point towards a diagnosis of tumor lysis syndrome, another oncological emergency in this child. So the next question is, what treatment should be started for managing tumor lysis syndrome in this child? And our options are starting IV hydration and urinary alkalinization, IV mannitol and furosemide, IV hydration with allopurinol, IV hydration with raspberry-case, or a hemodialysis. So these are the 5 options. In the subsequent slides, we would come to know which is the best correct response. Now, tumor lysis syndrome is a unique biochemical and clinical abnormality which is seen in children with cancer or even adults with cancer. It is caused because of rapid and massive tumor cell lysis. And because of this cell lysis, the intracellular components are released outside the cell, which includes breakdown of nucleic acid leading to production of uric acid. And this excess of uric acid deposits as uric acid crystals in the kidney, causing obstructive neuropathy, release of phosphate from the cells, which binds to the calcium, leading to formation of calcium phosphate crystal, again deposits in the kidney. Children are sick, so there is volume depletion, which exaggerates the kidney injury. patients also develop metabolic acidosis, and this acidosis further increases the precipitation of uric acid in the kidney. So all of this leads to kidney injury, leads to oliguria and anuria, which causes hyperkalemia. And also potassium is released from the malignant cell. This exaggerates the hyperkalemia. Hyperkalemia can lead to arrhythmia. This oliguria and anuria can lead to uremia and also can lead to fluid overload. So this is the entire pathophysiology of tumor lysis syndrome. How do we define tumor lysis or TLS? The Cairo-Bishop definition, which was given in 2004, it comprises of lab TLS and clinical TLS. So TLS is divided into two types, lab TLS and clinical TLS. For lab TLS, if among these four, any two lab parameters are fulfilled, the child would be labeled as suffering from lab TLS. And these four things are a high uric acid, a high potassium, a high phosphate, or a low calcium. So any two of above four. If a child along with lab TLS has any of these three abnormalities, which are not explained by any other cause, like he should not be a patient of AKI from or a CKD to begin with. So it should not have any other alternative explanation. So lab TLS with increase in creatinine, with seizure, or with cardiac arrhythmia or sudden death. So such a patient would be labeled as clinical TLS. Now, who is at risk of developing TLS? So these risk features are based on tumor histology, the feature of the disease, and the host factor. So tumors like Burkitt's lymphoma and leukemia, lymphoblastic leukemia, lymphoma, AML, and diffuse large B-cell lymphoma. So basically, non-Hodgkin's lymphoma and acute lymphoblastic leukemia and AML are those which are at high risk of going into tumor lysis syndrome. Bulky tumors, tumors with high LDH, tumors which proliferate very rapidly, and those which are very sensitive to chemotherapy. All these are at risk of developing TLS. And children who have a pre-existing CKD, who are volume depleted, suffering from sepsis, or are taking concomitant nephrotoxic agents are again at risk of developing tumor lysis syndrome. So the biochemical abnormalities in our child, looking at these, he is fulfilling the, at least there should be 2 abnormal values. He has all the 4 abnormal values. And over that, his creatinine has also increased from the baseline normal value to a value of 2 milligrams per DL. So he is fulfilling the criteria for clinical TLS. So this child has landed in clinical TLS. So how do we prevent and treat TLS? So the general principles for management of TLS are aggressive volume repletion, correcting the electrolyte abnormalities, prevention and therapy for hyperuricemia. Initially, we used to alkalinize the urine, but this practice has now been given away. And we may have to use hemodialysis or hemofiltration in advanced cases of TLS. So coming to the fluid and electrolyte management of TLS. So volume repletion is the cornerstone of managing TLS, both prevention as well as treatment. By volume repletion, we increase the solubility of uric acid, we dilute the uric acid, we dilute the phosphate. So volume repletion is very, very effective. So by volume repletion, we mean that using 2 to 3 liter per meter square per day of IV fluids. That is almost double the normal maintenance fluid. And once we are using such high volume of fluid, we have to ensure that the urine output is at least between 3 to 5 ml per kg per hour. If the urine output is less than 3, we should use diuretics like furosemide to achieve the normal urine output. So ensure double the maintenance rate of fluid administration and a good volume of urine. So this would ensure that all the abnormal metabolites like uric acid and phosphate are passed in the urine. If the child is showing features of hyperkalemia, his potassium is high, then make sure that potassium is eliminated from the IV fluids. Monitor the ECG of the child, and based on presence or absence of ECG changes, the treatment of hyperkalemia is standard for any pediatric patient. So with ECG changes, use calcium gluconate. If no ECG changes, only hyperkalemias, and you have option of using soda bicarb, insulin dextrose, salbutamol nebulization. So these methods can be used to treat hyperkalemia. Coming to hyperphosphatemia and hypocalcemia, again, hydration and diuresis is the cornerstone for treating hyperphosphatemia. Restrict phosphate from the diet. For children who are taking oral diet, phosphate binder may be considered. The phosphate binder, which is now easily available is sevelamer. It has to be used in a dose of 400 to 800 milligram thrice a day before each meal. Calcium should not be supplemented unless and until child is showing clinical features of hypocalcemia, because phosphate is high. If you give calcium, it will bind to the phosphate and lead to precipitation of calcium phosphate. So whenever the calcium phosphate product is beyond 60 mg square per dl square, the chances of precipitation are quite high. So calcium supplementation should only be used if the child is showing clinical features of hypocalcemia. Alkalinization of urine should be avoided because in an alkaline urine, precipitation of calcium phosphate increases. So while alkalinization decreases the precipitation of uric acid, it increases the precipitation of calcium phosphate. That is why the practice of alkalinization of urine has now been done away with. We do not prescribe soda bicarb for alkalinization of urine in children with TLS. So we have taken care of his potassium by using the measures explained. Calcium we are not supplementing because there is no features of hypocalcemia. For phosphate, we have started diuresis, hydration, and sevelamer. The only thing which is left is a high uric acid and high creatinine. So what to do for this high values of uric acid? This is the metabolic pathway of purine. Adenosine and guanosine both are converted to xanthine, which is converted to uric acid by the enzyme xanthine oxidase. Now we have two types of drug. One is allopurinol, which is an age-old drug used for patients with gout. It is a xanthine oxidase inhibitor. It inhibits the production of uric acid. So if we use allopurinol in such children who are likely to develop TLS, the production of uric acid will go down. But the demerit of allopurinol is one, it does not act on uric acid which has already accumulated. So if a child has a high uric acid, for example, our case, his uric acid is already 18. So giving allopurinol is not going to decrease that uric acid. It is just going to reduce the formation of further uric acid. Also, with use of allopurinol, the amount of xanthine and hypoxanthine starts to accumulate. And there is an entity known as xanthine deposition, xanthine nephrotoxicity can happen. So for children who have very high values of uric acid, allopurinol is of limited use. For such patients, we now have a molecule that is recombinant urate oxidase or raspberry-case. It acts on pre-existing uric acid and converts into a water-soluble compound known as allantoin and hydrogen peroxide, which can be easily excreted in urine. So for management of hyperuricemia, hydration and diuresis again have to be done. Alkalinization may increase the solubility of uric acid, but it does not have any effect on solubility of xanthine and increases the precipitation of calcium phosphate. So we do not alkalinize urine anymore. We can use drugs like allopurinol, which is a xanthine oxidase inhibitor, or raspberry-case, which is a recombinant urate oxidase for treating hyperuricemia. The dose of allopurinol which is used is 100 milligram per meter square given thrice a day, but it does not reduce the pre-existing uric acid, and it's a slowly acting drug. And it has a potential for xanthine nephropathy because xanthine starts to accumulate once you inhibit conversion of xanthine to uric acid. Raspberry-case is a relatively newer drug, much more effective, rapid onset of action. Even doses as low as 0.02 milligram per kg can be used and they are effective. Urinary alkalinization is not required if you are using raspberry-case, and it is the drug of choice for children who are at high risk of TLS. But one thing we have to make sure that G6PD deficiency is excluded before using raspberry-case because it can cause hemolysis in these children. Another demerit of raspberry-case is it is much more expensive as compared to allopurinol. So what are the indications of doing hemofiltration and hemodialysis? So if these lab values, abnormal lab values, are refractory to your medical therapy, they are rising along with the rise in creatinine, along with oliguria. This means that child's kidney has suffered severe damage, serious injury, is unlikely to respond to your medical treatment. Such a patient would be a candidate for doing hemodialysis. If a child has developed acute oliguric or anuric renal failure, he or she should undergo a dialysis. If he has developed pulmonary edema due to fluid overload, again, should undergo a hemodialysis. To summarize the management of tumor lysis syndrome, first step is to stratify your patient whether he or she falls in high risk, intermediate risk, or low risk. So high risk includes Burkitt's lymphoma, ALL or AML with TLC of more than 1 lakh per cubic millimeter. Intermediate risk includes a DLBCL type of non-Hodgkin's lymphoma, or ALL with a count less than 1 lakh, or AML with a count between 25,000 to 1 lakh. Or low risk, which is a slow growing non-Hodgkin's lymphoma, or AML with a count of less than 25,000. ALL is never a low risk candidate for TLS. They always are at risk of developing TLS, so they have to be managed appropriately. So after evaluating the risk factor, if a patient is at low risk of developing TLS, then use your clinical judgment and monitoring. No need to start prophylactic drugs. Patient with intermediate risk of developing TLS, start your IV hydration at double the maintenance rate. Start with allopurinol. But if even with this treatment hyperuricemia is developing, then initiate rasburicase. For children who are at high risk of TLS, hydration plus initial management with rasburicase is advocated. With any of these risk categories, it is extremely important to monitor the patient. Monitor his uric acid, potassium, calcium, phosphate, creatinine, and urine output. At baseline, 4 hours after the first dose of chemotherapy, and every 6 to 12 hours till all these values normalize. This was all about the hyperleukocytosis and leukostasis. So in our case, that is case A, the management which should be advocated, the child had clinical TLS, so he should be receiving rasburicase along with IV hydration. We would prefer using rasburicase in our case. The next complication is hyperleukocytosis or leukostasis. It is defined as any child with a total count of more than 50,000 to 1 lakh per cubic millimeter. And leukostasis is hyperleukocytosis along with clinical symptoms. These clinical symptoms would be respiratory in the form of tachypnea, retractions, or neurologic in the form of coma, altered sensorium, seizures. This hyperleukocytosis is common in AML, ALL, and children with CML in blast crisis. The first choice of treatment is to initiate chemotherapy. As soon as you initiate chemotherapy, these symptoms would subside because the TLC or the counts go down. But again, these patients are at high risk of developing tumor lysis. So initiate chemotherapy with prophylaxis for TLS. If a child is quite sick, you are not able to initiate chemotherapy, and he's having clinical features of hyperleukocytosis, you may consider using drugs like hydroxyurea, which again are slow-acting drugs, would decrease the cell count to some extent. You can also consider using leukapheresis. If a child is having symptoms, for immediate relief of symptoms, leukapheresis can be done, and along with drug like hydroxyurea. So this was the lymph node biopsy of the given case. The biopsy reports came on 5th day. You can clearly see these are the abnormal blastic cells seen in the lymph node. And these blasts were positive on IHC for cytoplasmic CD3, CD7, CD8, and TDT. TDT is a marker for immaturity, so it's an immature lymphoma. CD3, cytoplasmic CD3 is a marker of T cells. So this child has T lymphoblastic non-Hodgkin's lymphoma. So T lymphoblastic means immature, so immature type of T NHL. The markers for B cell, that is CD10, 19, and 22 were negative. So this child, after these reports were available, was initiated on induction chemotherapy. On day 8 of his chemotherapy, he comes back to the hospital with fever of 102 degrees Fahrenheit. And his CBC values showed a hemoglobin of 8.5, a total leukocyte count of 1100, with a polymorph of 20%, lymphocyte of 80%, and platelet count of 35,000. So his absolute neutrophil count is only 220. So this child has neutropenia along with fever. So this is another oncological emergency, that is febrile neutropenia. How do we define febrile neutropenia? It has two components, neutropenia and fever. Neutropenia is defined as any child with an absolute neutrophil count of less than 500, or with an ANC of less than 1000, but with an anticipated fall to less than 500 in 48 hours. So how do we anticipate this? So this is anticipated based on the timing of chemotherapy. If we have used a cytotoxic chemotherapy on day 0, we expect that peak response would be on day 7 to 10. So if the child's ANC is say 800 on day 6 and he has fever, then we expect that in next 2-3 days his counts are going to fall further. So he would also fulfill the criteria for neutropenia. The next component is fever. So fever is defined as any single episode more than 101, or if a single episode of 100.4 is sustained beyond 1 hour, it would be labeled as fever. So our child case A has febrile neutropenia because his ANC is 220 and he had a fever spike of 102. So febrile neutropenia is an emergency. While in other pediatric subspecialties, general pediatrics, we talk about refraining from antibiotic use, but in children with febrile neutropenia, we should never delay use of antibiotics, because most of the children with febrile neutropenia have a pyogenic underlying cause. So bacterial infections are the most common reason for febrile neutropenia. So proper initiation, early initiation of antibiotics is extremely important. So send appropriate cultures, do imaging studies, and do not delay antibiotics. Now, the choice of antibiotics is based on the antibiogram of your individual ward. Most of the times we choose an antibiotic which is broad spectrum, should cover gram-negative organism. So the choice which can be made is something like cefoperazone sulbactam or piperacillin tazobactam or a carbapenem or a cefepime. So these are the options which you have to choose based on the susceptibility pattern of your individual oncology unit. I'll run through the next complications. So this was all about the case A. So he had a tumor lysis, he had superior mediastinal syndrome, and he also developed febrile neutropenia. So same child can develop various oncological emergencies which needs proper management. Now coming to the next child, a 7-year female who presents to us with a back pain of 1 month and now has developed acute onset paraparesis of a short duration of 5 days, along with loss of bladder control of 5 days. There is no hepatosplenomegaly, no lymphadenopathy. She also has come with an MRI of the spine. And this MRI of the spine, you can appreciate that there is destruction of the vertebrae along with compression of the spinal cord. So this is the cord. There's a mass here which is compressed, destroying the vertebra and compressing the cord. So this child is suffering from neoplastic cord compression. The point which should be highlighted is back pain. Never ignore back pain in a child. While adults, back pain can be of various reasons, may not have a cause all the time, but in children, back pain is uncommon. It should never be ignored. It may be one of the signs of a neurological problem or the underlying malignancy in the vertebral column or the spinal cord. So spinal cord compression can again be because of various type of neoplasms, and the compression can arise from deposits at various places. The commonest sites are the vertebra. So neoplastic deposits from leukemias, from germ cell tumors in the vertebra can cause cord compression. There can be leptomeningeal metastasis from the leukemia, which can also cause compression. And sarcomas like Ewing sarcoma and rhabdomyosarcoma, neuroblastoma can at times cause epidural metastasis, again leading to cord compression. So clinical feature, most of them would present with back pain. Later on, they can develop motor sensory deficits. They can develop sphincter abnormalities. Initially, an imaging, preferably an MRI, should be obtained. But again, MRI would only tell you that there is something here. There is a neoplasm here, but it will not tell you which neoplasm it's there. So a tissue diagnosis is must. And along with tissue diagnosis, we need to decompress the spine because permanent neurological damage may happen. So spine decompression has to be done. The options which you have are steroids, laminectomy, radiotherapy, or chemotherapy. So which one to choose? So whenever you have a clinical suspicion of neoplastic spinal cord compression, first thing is to administer DEXA, because DEXA would reduce cord edema, would relieve the symptoms to at least some extent. So start DEXA at a dose of 1 to 2 milligram per kg, followed by 0.25 milligram per kg every 6 hourly. Obtain MRI for confirmation, and then try to decompress the cord. So this decompression can be done either by laminectomy or by radiotherapy or by chemotherapy. Which one to choose? So if the primary malignancy is known, you know that the child has leukemia, ALL, and has cord compression, you just start with your chemotherapy. But if you do not know the primary malignancy, then obtaining tissue is mandatory. So in such a scenario, laminectomy has to be done. So laminectomy would cause decompression as well as provide you with tissue for obtaining the diagnosis. But laminectomy is associated with high morbidity, so it is not routinely performed for all cases. It is reserved only if the primary malignancy is not known, if the tumor is rapidly progressive, or if he or she is not responding to radiotherapy of chemotherapy. So if the primary malignancy is known, if the tumor is not rapidly progressive, start your treatment. If it is radiosensitive, start radiotherapy. If it's chemosensitive, start chemotherapy. If the child is responding, continue with your treatment. If the child is not responding, if the tumor is rapidly progressive, or if you do not know the malignancy, then laminectomy by a neurosurgeon has to be done. So this was all about the oncological emergencies. So the key messages are, whenever you are encountering a child where you are suspecting malignancy, anticipate tumor lysis in high-risk condition. Be aware that these are the high-risk conditions. A child with Burkitt's lymphoma, ALL, high count AML, they may develop TLS, and start your treatment accordingly. Hydration is extremely important. So use hydration, monitor urine output very closely. If uric acid is high or there is high risk of TLS, use raspberry case. In a child with superior mediastinal syndrome, avoid sedation. Use the least invasive diagnostic method. Start dexamethasone as soon as a neoplastic cord compression is suspected, because it would reduce the cord edema and relieve the symptoms, and then go for the diagnosis. Febrile neutropenia is an emergency. Start antibiotics as soon as possible after obtaining your cultures and microbiological data. So this was all about my presentation. If there are any questions in the chat box, I'd be happy to take.
Thank you so much, sir, for such a lucid presentation and explaining it so beautifully around the cases you discussed. I believe there are no queries in the chat box. So thank you so much, sir, once again.